Good morning, everyone, and thank you for joining us today. I'm Cheryl DeMars. I'm the President and CEO of the Alliance, and it's my pleasure to introduce today's program, which features John Barlament, who is an Alliance member favorite. John is going to bring us up to date on some important health policy and regulatory issues that will impact employer health benefits and the market. Many of these policy issues are evolving, and so our focus today is going to be on what we know now and what this means for your health benefit plans. We'll follow up in a future session to discuss the strategic implications and what we think are real opportunities for employer-sponsored plans to drive better value healthcare at a future date. Just from a housekeeping perspective, there are over 250 people tuning in this morning to today's webinar, and you're all in mute mode, but we want to hear from you. And so we ask you to use the chat feature to ask your questions. Many of the regulations that you'll hear about require action on the part of your health benefit partners. And so to help you manage those accountabilities effectively, John has prepared a checklist for you to use with your health benefit partners. You'll find that checklist in the GoToWebinar control panel. Just click on the download resources button to access that checklist. We'll also include a link to the checklist in the evaluation that you'll be receiving by email later today to give us feedback on today's session. And the checklist will be posted on our website, so that's another way that you can access this. I also want to thank our sponsors today, National Cooperative RX and Delta Dental. We appreciate your support, and you can find more information on our sponsors also in the today's event page on our website. And now it's my pleasure to introduce John Barlament, who is a partner for Quarles and Brady's Employee Health Benefits team. John provides practical assistance to plan fiduciaries, employers, multi-employee plans, insurance brokers, third-party administrators, pharmacy benefit managers, and plan service providers on a wide range of employee benefit topics, with a particular focus on health and welfare plan matters. He's an author of HIPAA Portability, Privacy, and Security, which likely serves as the nation's leading manual on HIPAA privacy and security rules for employee benefit plans. John has also authored a leading manual on health reimbursement arrangements and wellness plans called Consumer-Driven Healthcare. As a frequent national speaker on employee benefit topics, John is recognized as a national leader in these emerging and constantly changing areas of law. He's been quoted and interviewed by publications like the Wall Street Journal and National Public Radio. And John has become a friend and colleague, having spoken at Alliance events for over a decade. John, we really appreciate you being with us today, and we look forward to your comments.
Excellent. Thank you, Cheryl, and thanks everyone for being here today. Very excited to be here. We really have a full plate of topics to cover, which we're going to have to, again, kind of go through here slide by slide. And just wanted to make sure that everyone can see my slide 2, which is agenda items here. Cheryl, do you see slide 2? I just wanted to double check that.
Yep, you're all good.
All right, that sounds great. All right, so in terms of our topics for today, again, kind of a full plate. We're going to talk about a lot of new changes here, including some requirements related to the Surprise Billing and No Surprises Act, or NSA. Those are, generally speaking, part of a larger bill called the Consolidated Appropriations Act, or CAA. And the CAA has a whole host of different changes which employers and their group health plans have to comply with. As Cheryl hinted at, though, a lot of the burden here, I think, is going to fall upon your service providers, your TPAs and PBMs, to try to comply with these different rules. So you'll hear that as kind of a consistent theme throughout the presentation of, okay, here's kind of a in the weeds, nitty gritty kind of change which has to occur you're probably not in a good position to do it if you are an employer, but your TPA is probably in a good position to do it. So your goal is going to be talking to the TPA, making sure that they're going to do these activities. If they're not going to do the activities, understand that, but presumably they should do most of this for you. Probably getting it in writing, making sure that they, do this, and also double checking what they're going to charge. We know that a lot of TPAs will charge for some of these activities. So again, those are kind of the main moving parts here with respect to those changes. We'll also talk about some certain patient protection regulations, which are updated. There's some changes there, especially for grandfathered health plans. We have sort of a grab bag of other legal changes and updates. And buried in that grab bag, and we'll definitely emphasize it, we have a couple slides on it, and this might be the top priority item for some employers, is some new IRS guidance that came out last week on COBRA. What's so hot about COBRA? Well, as you may recall, due to the pandemic, individuals generally had about a little bit longer than a year to elect COBRA, a little bit longer than a year to start making payments for COBRA. And the prior guidance suggested that that could go on for potentially years. The new guidance from last week cuts that back. It's actually kind of a win for employers, but the problem is that you may have communicated the opposite to your employees. So you may have to take action pretty quickly to clarify what these new deadlines are, because your plan enrollees may think that they have a lot longer. So we'll talk about that one. Again, that's sort of a late breaking development here.
Hey, John, let me interrupt
Yeah.
just for a second. I can anticipate one of the questions our employers or the participants
Sure.
today will ask, which is, will the slides be available?
Mm-hmm. Absolutely. And they will be available, to my knowledge, at least, Cheryl. Yeah, I'm not quite sure the method for distribution, but I'm assuming that they will be distributed.
Great. If you're fine with us sharing them, we'll figure out how to make sure that gets done. Maybe even putting a link in the chat feature or sending a link out through the evaluation. Thank you.
Sure, absolutely. No, you can definitely share them for sure. Absolutely. Yeah, and hopefully they're valuable here. So in terms of the new changes, where are we going? Well, it's funny, a lot of times when I give presentations on changes to health policy here, well, a lot of what drives it tends to be rising medical costs. And that goes back to the initial kind of failed Clinton healthcare reform, goes back to the Affordable Care Act, and it's the same, song, different verse here. Rising medical costs are causing Congress to, again, on a bipartisan basis, the CAA was passed by Congress, signed into law by President Trump. This is not a Democrat initiative. It's not a Republican initiative. It's a joint initiative of, again, trying to find ways to control health plan costs. And sort of the new marching orders here, kind of the new national goal, which the federal government is really moving towards, is price transparency as a way of controlling health plan costs. The theory being that if we can have a policy of people in the industry, the providers, the TPAs, the PBMs, the insurers, everyone sort of revealing their previously negotiated costs, and those costs are often secret. We'll talk about the alliance in a second. But the theory is that if these costs become known, then maybe the providers will start competing more on price, and maybe it'll drive down costs, maybe it'll create greater efficiencies in the whole healthcare system. Interestingly, the Alliance has actually been active in this area previously, sort of ahead of the curve in terms of promoting price transparency, not having gag clauses. We'll talk about gag clauses later on, not having those types of clauses in their contracts. So interesting. I think the rest of the country is kind of catching up to the posture that the Alliance has previously implemented successfully. So interesting to see that, but also good. The questions we have at the bottom slide there: will greater price transparency drive down costs? Or some would argue that it might enable providers to compete less on price. Maybe providers will say, hey, my main competitor down the road, they charge, $40,000 for a knee surgery. We're only charging $30,000. Maybe we should bump it up to $40,000 so that we're all kind of similar. Or maybe it's just the opposite. Maybe the $40,000 provider says, oh, we need to start charging $30,000 to compete with our competitor down the road. So I don't know. I mean, that's the $1 million question, or in the healthcare context, the multi-billion-dollar question here. How will all this play out? So it's a good question. You're not going to get an answer to it here today. We're not going to tell you if this will succeed or fail from a national policy perspective, but that's what Congress is thinking, and that's where they're steering the ship. If that makes sense. So one of the big issues that the No Surprises Act, again, part of the CAA, deals with, and this has been a lingering issue really for a long time, is how to handle out-of-network medical claims, especially when the plan enrollee did nothing wrong, if you will. And I've seen this pop up numerous times. I work with some clients where they have committees and they ask me to join committee meetings, and this situation has popped up many a time where a plan member maybe wants to have a surgery, and the member is very careful about going in-network, wants to minimize the costs. So the member finds an in-network hospital, in-network surgeon, has the surgery done, but suddenly a specialist, maybe an anesthesiologist, is out of network. At that point, it's kind of too late. You can't pull the plug on the surgery. And so the person goes ahead with it. And then they get hit with a big bill for this out-of-network specialist. Done it, even though the member did everything right, should they be required to pay for out-of-network services? And then second, what should the plan pay for that out-of-network provider? By definition, being out-of-network, there really is no contract in place with that provider. How does the plan figure out what's a reasonable amount of money to pay in that situation? And so there's some new regulations here, came out in July, which really kind of delve into the weeds in terms of answering this particular question. And again, protecting enrollees is very important, but the regulations also try to protect the providers. We want to make sure that the anesthesiologist in this example, gets paid a fair amount, maybe not overpaid, maybe not exactly what they're looking for, but that's sort of the main policy goal. So these regulations here, which we'll go through in the next couple of slides, generally start for a plan year starting January 1, 2022, which is not very far away as we sit here in the middle of October. I had personally hoped for a kind of a delay, that maybe some of this would get delayed. And as we'll talk about, some of it did get delayed, but not this piece. So again, we'll kind of call out the different effective dates here. So in terms of dealing with this new No Surprises Act rule here, we think that it will require some coordination between the plan and the provider. And when I say plan and provider, I'm really talking about your TPA, or in some situations, maybe your PBM, but usually PBMs would not be involved in this kind of claim. Usually it's just TPA driven, even if there are prescription drugs which are provided in the hospital context. And they're going to have to talk to each other. One of the most basic questions is whether or not that plan enrollee has waived these protections. Interestingly, there's a way that they can waive all their protections, and then all these rules that we're talking about here suddenly drop out and they don't apply, and then we're back into the pre-CAA world where the enrollee could be balance billed and everything else. So one of the initial things is trying to figure out, okay, what rules even apply? And again, your TPA, I think, is going to have to talk to the provider to verify, did the enrollee waive their rights when they walked into the hospital or came in through the emergency room, et cetera. So what are the protections here? 5 main items. First of all, it provides protections for the enrollee against balance billing and out-of-network cost sharing. So again, the goal here is to sort of treat these particular expenses, the 3 expenses you see here, as sort of in-network expenses, even if they're technically out of network. So the first one being emergency services. So if a plan enrollee goes down to Florida on vacation, they get hit by a bus, they're taken to a local hospital down in Florida, it's out of network. Again, the protections would apply, generally speaking, in that context for that enrollee, where they're going to be treated sort of as if they are in network, wouldn't have any kind of balance billing, again, unless the enrollee has waived their protections here. Non-emergency services furnished by a non-participating provider at a participating healthcare facility. That's the example that I gave involving that anesthesiologist. The plan enrollee did everything right, went to in-network, but unfortunately, there was an out-of-network provider who just kind of showed up and billed some amount. So again, special protections there. Last one is probably the most rare one, air ambulance services. I don't know if any of you have ever seen an air ambulance claim. They can be tens of thousands of dollars, hundreds of thousands of dollars, usually very difficult situations. Someone was involved usually in an accident in a remote part of the country, had to be flown to a hospital, which could be 100 or more miles away, maybe across different state lines. And those tend to be very expensive services. So there's some special rules in that context also. So that's in general what they do. They also prohibit balance billing by the providers, again, trying to protect the enrollees in that context. They will require certain disclosures of the federal and state patient protections against balance billing. So there's some new language, there's some new notifications, which again have to be sent out. Again, I think the goal here as an employer is to lean on your TPA to provide that type of notice. And we'll talk about it a little bit more later. The new rules also recodify certain patient protections of the Affordable Care Act and apply them to grandfathered health plans. If you have a grandfathered health plan, double check this because this is new. One of the advantages of being grandfathered was that certain patient protections, such as the ability to choose particular providers, didn't apply to a grandfathered health plan. Now they do apply. So again, sort of a curveball here where some of the advantage of being grandfathered just got chipped away at. Still, other things do apply if you're grandfathered, where again, there are some advantages to it, but again, this weakens the advantages of being grandfathered by just a little bit at least. There's also a new complaint and audit process for violations of these protections, and so we'll talk about those in a little bit more detail here too. These new regulations, fairly long, creates lots of new definitions. Again, not sure that you want to get into the weeds of what exactly an air ambulance service is, an independent freestanding emergency department, an IFED, a non-participating emergency facility, a NEF, et cetera. So lots of different definitions were, because this is directed at the employer level as opposed to the insurer or TPA level, we're not going to get into all the nitty-gritty and the weeds in that context. We'll try to go through it fairly quickly. Again, the last bullet point is sort of the summary for you, making sure that your vendors comply with it, and then updating your plan documents and SPDs to comply with these new rules here, to make people aware that, okay, in the past, maybe you could have been balance billed, or maybe some of these services would be treated as kind of out of network expenses. Now they may be in network. So again, clarifying your plan documents, I think, is the main goal here, and making sure that your vendors take care of this is the main goal for you as plan sponsors.
Hey, John, just a quick clarifying question, if you don't mind my jumping in. We got a question asking about if the air ambulance regulations also apply to ground transport ambulances.
No, I don't think that they do. I think it's really just air ambulance. I think it's pretty clear in the regulations there. So, and ground ambulance can be expensive, but in my experience, not nearly as expensive as the air ambulance. So I think that Congress just determined that air ambulance is in its own category, basically, and it needs special protections. So no, I don't think it's ground. Yep. All right. So in terms of, again, kind of getting into details a little bit more, hopefully without going too deep into it, what do these new regulations say? They say that if a plan provides or covers any benefits with respect to an emergency department, and most plans do, it would be strange to exclude emergency department costs, then the plan has to cover certain emergency services. Emergency services are basically what a prudent layperson would think is an emergency. That definition is sort of a win for patients and providers because in the past there have been some controversies. Some of the big insurers in particular had been kind of aggressive in saying that certain services really were not emergency services under the Affordable Care Act, where there's some special rules. The classic example is the enrollee goes to the ER for a heart attack, but it's just heartburn. If they had taken some antacid, they would have been fine, but they thought it was a heart attack. Is that really an emergency? Do these special emergency rules apply? Again, the federal government has kind of put its thumb on the scales of saying, well, what would a typical kind of prudent layperson expect in that situation. In other words, it's more likely that that really is going to be treated as an emergency, even though in retrospect and with perfect hindsight, all of us would probably agree that that wasn't really an emergency. Also includes certain post-stabilization services. So again, if you have this kind of emergency services, then what rules apply? Several rules. The first one being that your health plan, needs to cover it without any prior authorization determination, even if the service is out of network. That's again, vacation in Florida, get hit by a bus. You need to cover it, even if I didn't, if I'm the one who got hit by the bus, even if I didn't seek prior authorization. Cover it without regard to whether the provider is a participating provider or participating emergency facility, without limiting what constitutes an emergency medical condition, so only on the basis of diagnosis codes, so kind of delve into the details there, without regard to any other plan term or condition, other than certain ones which you might expect, for example, waiting period. If I'm not yet in the plan, then you can exclude my expenses in that situation. So there are a couple narrow situations where, again, you can exclude emergency services. If the service is provided by a non-participating provider or a NEF, like we defined before, not impose any other administrative requirement or limitation that's more restrictive from in-network providers. Not impose cost-sharing requirements that are greater than the requirements that would have applied in the in-network setting. So again, taking a step back, what we're trying to do is we're trying to basically treat them as if they were basically in-network in that context. So plan enrollees are protected. They don't get hit with giant out-of-network bills in the emergency context. Again, that's kind of what's going on here. How much are providers going to get paid? There's kind of a defined term called a recognized amount. Cost sharing, what my copayment, what my deductible, coinsurance would be, is going to be based upon this recognized amount. And again, now we're starting to get kind of into the weeds. I'm trying to keep us a little bit higher level, so we're not going to necessarily delve into all of those terms, but just know that there are kind of set payments here that have to be made. One of those is called an initial payment, and what the TPA is going to have to do on your behalf is sort of identify if there's a state law which applies, and ERISA may preempt it, so that's kind of a whole different issue. But figure out if there's a state law which applies, which dictates what that initial payment is going to be, and if so, follow it. If there is no state law, then it becomes a little bit harder to determine. The plan has to kind of come up with sort of this amount which they think is reasonably intended to be payment in full based upon the facts and circumstances. So again, it gets into the kind of nitty-gritty area here of what actually has to be paid. If the provider accepts the initial payment, plus whatever the enrollee had to pay as cost sharing, then the NSA protections don't apply and everyone's happy. There's nothing else that goes on. If they don't like it, so if, again, they say, hey, when John got hit by that bus in Florida and he had all these severe injuries, we think that the cost was $100,000. You're telling us that you're only going to pay us $60,000. Again, if the provider accepts the $60,000 for my medical expenses, we're fine, we're done. If they say, no, we don't accept that, then there's a whole new process, and we'll go through this in a little more detail later. Basically, it kicks off this 30-day negotiation period. If they still can't agree, then there's something else called an independent dispute resolution, an IDR process, which applies, where they sort of bring it to a neutral third party, and the neutral third party has to figure out what's an acceptable payment. So again, a whole new process. In the past, that did not happen. In the past, it was just sort of an arm wrestling competition. Your TPA would, kind of go back and forth with that provider. Maybe there'd be a lawsuit, perhaps. But again, it was sort of just kind of a staring competition between your TPA and the provider. Now that's not true. Again, now we've got a very set new process, brand new process, which is out there. And again, as an employer, I think your TPA will handle this, but you need to double check that. You have to make sure that they're not just going to turn around and say, hey, employer, this is really complicated. Why don't you handle it? That would be, I think, probably pretty bad from your perspective. So again, that's sort of your task there. And Part E here, the plan has to pay to the non-participating provider facility the amount by which the out-of-network rate for the services exceeds the enrollee's cost-sharing amount less the initial payment. That payment has to be made within 30 days. So again, kind of nitty-gritty there. And then you, as the plan or plan sponsor or as a TPA, have to count any cost-sharing payments that made by the enrollee towards an in-network deductible or in-network maximum out-of-pocket, as if the services were done in-network. And again, in this hypothetical of me getting hit by a bus down in Florida, it's out-of-network. There's no contract, but I still get treated as though it's in-network. That's the basic goal there with respect to that. All that I realize is pretty high level, and so I looked in the regulations for an example. You would think that there'd be kind of a nice example, and there really is no example in the regulations, which is kind of a weird thing. Normally the agencies are a little bit better at putting in some kind of example. There was an example in the preamble dealing with high deductible health plans, so I thought I'd put it in here. Let's suppose that the employee is enrolled in a self-only high deductible health plan, $1,500 deductible, no other claims in the current year, then again gets hit by a bus, out-of-network emergency services. Plan determines that the recognized amount is $1,000, maybe only grazed by the bus, maybe not hit by the bus. The employee has to pay that amount, but the provider wants $1,500, and that is deemed to be appropriate. Plan must pay the difference between the out-of-pocket network rate and the cost-sharing amount. So the plan pays $500 in that situation, $1,500 minus $1,000. The employee's out-of-pocket amount is limited to the cost-sharing calculated under the recognized amount of $1,000. So the plan's payment of $500 before deductible was satisfied would normally cause a loss of HSA eligibility. So in other words, the plan is paying $500 even though the employee hasn't hit their deductible. But the NSA has modified Code Section 223 to prevent that. So 223 is the HDHP, high deductible health plan rules, the HSA rules. So again, this could require, I think, in theory, a change to your plan or SPD. If you have a high deductible health plan, it may have language in it right now talking about how, in general, the plan will not pay until the person has hit their deductible. In this kind of narrow situation, this is an exception to that rule. So again, this may require you as a plan sponsor to update your plan and SPD and explain, in general, high deductible health plans don't pay for anything except for preventative care. This is another exception, just like preventative care. So annual physicals and other, vaccination shots and things like that. And this is another exception, which again, you may want to mention in there. All right. The next piece of the NSA, non-emergency services by non-participating providers. Again, if the plan covers non-emergency services, there's going to be certain protections with respect to this anesthesiologist who kind of jumps in, following up on my example. No cost sharing greater than what they would have paid for an in-network provider. Calculate the cost sharing as though the payment is going to be based upon this recognized amount, i.e. kind of this amount that we're going to be paying here. Within 30 calendar days after it's been determined the amount is sufficient, your TPA has to pay the provider the initial amount or send a denial notice. Make total plan payments to the out-of-network provider equal to the amount by which the out-of-network rate is applicable here, less this initial payment amount. And again, count the cost-sharing payment. So if I make some kind of cost-sharing payment in that situation, even though it's technically out of network with respect to the anesthesiologist, your TPA needs to make sure that it's counted as being an in-network expense, going towards my in-network deductible, in-network maximum out-of-pocket. So again, those are changes because we're kind of dragging out-of-network expenses into the in-network category, and your plan documents need to be updated to reflect that because they're not likely to say that here today. All right, air ambulance surprise bills. Very similar rules. You can see, based on the first two categories of protections, you can see where we're going. It's basically the same thing. Cost sharing as if they were in network, payment of the qualifying payment amount. Payment has to be made within 30 days. It's going to count as in-network expenses, even though it's out of network from a traditional contracting perspective. So again, it's that sort of kind of nitty-gritty. Moving those what are traditionally out-of-network expenses into the in-network category. high level, that's what you need to know as a plan sponsor. And again, the nitty-gritty details of what is a qualifying payment amount, which we're going to talk about here, what are these different rates. Again, make sure that your TPAs are handling that aspect of it for you. All right. If you're curious what a qualifying payment amount is and what some of these different amounts are, this slide and the next one has just a little bit of details here. There are some states which kind of set rates in this context. They've kind of said this is crazy that that there's no contract. Let's kind of set the rate. So some states do that. Other states don't do it. The agencies estimate that there's about 2/3 of all claims which involve non-participating providers, which may end up qualifying for these special qualifying payment amount rules. But again, others will not. The basic idea of what the qualifying payment amount is at the second bullet point. It's the median of the contracted rates recognized by the plan on January 31, 2019 for that type of service. And then it's adjusted for inflation. So again, if you're curious, morbidly curious what the plan is going to have to pay, again, that's the baseline here. Is you look at what the plan would have paid back in January of 2019 for that same kind of service. So if I'd been hit by a bus back in January 2019, what would my costs have been versus if I get hit by a bus in January 2020? And again, all that is out of network. That's the kind of dollar amounts that you're talking about. That's kind of the fixed point where we're kind of moving forward and again adjusting for inflation. All right, so that is a lot of detail. My apologies. Just wanted to mention enforcement here too, because there are some unusual enforcement and audit provisions. The IRS and DOL are tasked with actually enforcing this and doing random audits. So random audits are actually required here. So it's possible that you will see some kind of IRS or DOL audit. Again, that heightens the concern and makes it even more imperative, I guess, that you talk to your TPAs and make sure that you have something in place here to make sure that they're following all of these rules. Plan enrollees can complain. They probably would have complained anyways, but they have a legal right to complain if this is not actually working according to how it's supposed to go. So just be aware of that. I also hinted at this previously that there's actually a new notice. The regulators sometimes like paper, and there's a new notice that relates to the NSA. Make sure that enrollees understand what rights they have here. So the new regulations from July in the preamble mentioned the notice is required and has to be sent with every explanation of benefit. And so, that's a lot of additional paperwork. Again, usually your TPA is sending that out. Talk to them, make sure that they're going to be sending out this notice. We do provide a link to it right below in case you're curious what it's going to say. But again, work with your TPA, make sure that they're doing that. Agencies may issue more guidance in the future. That's kind of us gazing into the crystal ball here, but we think that that is pretty likely. These July surprise bills, surprise billing regulations were specifically labeled as Part 1. Last week we got Part 2. I do anticipate that as they kind of develop this, there will be glitches which will pop up. They'll probably address that through separate regulations in the future. So there's a fair number of moving parts there. Kind of just keep your eyes open, or make sure that the TPA is keeping its eyes open for these different changes. All right, let me pause for a second here. Cheryl, do you know if there's any other questions so far?
No, I don't see any, John. Thank you though for checking in.
Okay, that sounds great.
Wait 1 second, there is one. In regard to surprise medical bills and the high deductible health plan portion of the presentation, is the members' cost sharing based on the initial payment or the IDR approved payment?
Yeah, I think it was based upon the initial payment. I probably have to double check how they phrase it in the preamble, but I thought it was based upon that. But that's a good question. I'd probably have to actually pull the reg, so I probably won't get an answer here, but I think that that's how it's written. Yeah.
Great, thank you.
Okay. All right, other changes here. Patient protections, we hinted at this at the beginning. We kind of talked about what we're going to be going through here. ACA Section 2719A provided for various patient protections related to emergency services, and the choice of a healthcare professional. For example, women had the right to select an OBGYN provider, which, probably most plans gave them that right, but some didn't, I guess. And so again, the ACA kind of strengthened those protections here. NSA did something kind of strange. They sort of sunset some of those ACA protections and then reinstate them actually a little bit more stringently with respect to the CAA and NSA. So some of those ACA rules phase out, the new ones apply. Interestingly, when Congress did that, they did not carry through the grandfathered health plans exception. So again, as I noted before, if you have a grandfathered health plan, which are still in existence, we have some clients with them, but I'd say the majority of clients have lost their grandfathered health plan status under the Affordable Care Act. If you have lost that status, this piece is not really a significant change. If you were grandfathered, this is a little bit more significant. So double check it. It will require you to probably update your SPD and include in some of the ACA language that your colleagues who have already lost their grandfathered health plan status, that they've had in place for a number of years. The agencies also republished certain regulations, just kind of minor technical changes there. Other CAA obligations. So I mentioned that there's kind of a whole host of different things which are out there, and there are. We'll go into some of these in a little bit more detail, but wanted to give you a heads up here. And changes to insurance identification cards, you'll probably see those roll out in 2022. We're expecting continuity of care, which is a very interesting provision, where if somebody's getting in-network care and they're in a really bad shape, really significant medical issues, and then that provider leaves the network, you may have to keep treating them as being in network, even after they've actually technically left the network. Again, same kind of concept that we talked about in the air ambulance and the anesthesiologist concept, taking what was an out-of-network claim and dragging it back into the in-network status is basically what's going on there. Provider directories, again, we'll kind of go through that. There's some changes there and some risk there if the information is incorrect. Prohibition on gag clauses, we'll spend some time on that. Pharmacy benefit and drug cost reporting. And then for some of these rules, the agencies said that they might not be any guidance until after January 1, 2022. They have said that later this year they will be issuing some guidance here on, for example, the independent dispute resolution process, the IDR process. Those were formally published a week ago, October 7th, and we have a couple of slides on those. Those are very nitty-gritty. Again, not a lot for employers to do other than be aware of it. It is possible that will cost you additional money because the IDR entity will charge for their services, and if you lose in the IDR process, there's a cost associated with it. And so, again, we do expect that TPAs will probably pass along those costs to you. And so, again, you have to be prepared for that additional cost here, we think. Transparency in patient-provider dispute resolution process and price comparison tools. Again, we expect some more guidance there. Other kind of new changes here. Air ambulance. We talked about the special protections for enrollees with respect to air ambulance. Interestingly, there's a brand new requirement too on reporting of air ambulance claims. Basically, the federal government determined that it didn't have enough information about how much air ambulances cost and sort of the other details associated with it. So last month, they came out with some proposed regulations on air ambulance reporting. Group health plans and insurers have to submit to HHS and possibly DOL and IRS. It's a little unclear. Certain information for calendar years 2022 and 2023 reported a year late. Detailed information about the services which were provided to the plan enrollees. The details are things that you will not know as employers, whether it was a fixed wing aircraft, whether it was a rotary, air ambulance, a helicopter versus a jet engine, I guess. And so there's a whole host of things which have to be reported. Again, net takeaway for you as employers is talk to your TPA, make sure that they're going to do this, figure out if they're going to charge for it. In the contract, verify what happens if they get it wrong, and if there's some penalties which are going to be assessed, who's liable for those penalties? Is it you? Is it the TPA, et cetera? So contracting is going to be important there. IDR process. I hinted at this in the other slide that just last week that we did get some new guidance about the IDR process. And again, these new regulations kind of start filling in some of the gaps here about how that process is going to work. And again, taking a step back, when does this apply? Think back to those slides when I talked about those emergency services, where again, the provider says, we think we should be paid $100,000. Your health plan says, no, we think you should be paid $60,000 for those emergency services. It's all out of network technically, so there's no contract in place. The two sides talk, they can't agree, and in the past they would just kind of stare at each other and try and figure it out. Again, now there's a whole new process where either side can invoke, either you or them, you being the TPA or your TPA client, or the provider, you can invoke this IDR process. And then this IDR entity will determine, okay, what should be paid? Is it 60,000? Is it 100,000? Is it 80,000? That's how it's going to work. The new regulations from last week really expand upon who can provide the IDR services. Net takeaway can't be someone who's biased. Can't be your TPA, can't be your PBM, can't be your insurer. You can't be one of my clients. I'd be pretty biased in your favor. So there's that kind of baked in conflict of interest rules. There are also a lot of administrative requirements of the IDR entity. They have to be trained. Their employees have to be trained. They have to comply with HIPAA-like data privacy and security rules. So these new regulations really flesh out, again, what has to be accomplished by the IDR entity. The costs. Interestingly, in the preamble, regulators talk about how they don't know what the costs are going to be. They're not going to set those limits. They're not going to set minimums. They're not going to set maximums. They do note some examples where they're aware of arbitration costs, which can cost thousands of dollars. But they say, we don't think it's really likely to cost that. We think it's probably more in the $300 to $600 range per claim, which goes through the IDR process. And so that seems hopefully like a better charge than, $300. Again, one of the big kind of net takeaways for employers, and again, these regulations are like 150 pages long. We're not going to go through the details because, again, it doesn't really apply to you. Just want to make sure that you're aware that there's this new process. And then what are your action steps? What are your takeaways? Again, talk to your vendors, making sure that they have a compliant process in place for those IDR rules. For example, under the regulations, your TPA is going to have to timely provide information to the IDR entity. If they don't, they're violating the law. If they're violating the law, arguably you're violating the law. So again, talk to your TPAs, make sure that you have a good process in place. I think that they'll take the lead in this process, but again, talk to them about it. The cost for the process, there's going to be some costs, I think. It's unclear to me what those costs really will be. It's unclear to me how often the provider will really assert this, how often the TPA will assert this. In general, what we've seen from clients is there's always a reluctance to go to litigation, always a reluctance to, go to arbitration because there's baked in costs associated with that. So I could see TPAs charging for it. So beyond the $300 or $600 that the IDR entity may charge, the TPA may charge something too. So again, this could be pricey. Presumably that means it will only apply as a practical matter in high dollar claims. But again, talk to your TPAs, try to figure out, okay, what is going to be the cost associated with that. In terms of other things that came out last week, as part of those same regulations, they also clarify certain external review requirements. And to take a step back, in case you don't remember, ACA said that non-grandfathered health plans have to send certain decisions which have been denied to a third-party external reviewer upon request of the plan enrollee for a binding determination after the appeals process has been exhausted. So it says, if you're a plan enrollee, you're still unhappy after you've exhausted all your internal appeals, you get one more crack at it if it involves usually medical judgment as the basis for denying the claim to this external reviewer. The CAA now expands the types of claims which are eligible for external review. now includes any adverse determination under Code Sections 9816 or 9817. What does that mean in plain English? In plain English, it means these types of things. It's the things we talked about before in the previous slides. Benefits in an emergency department or independent freestanding emergency department. It's the number 2 is the anesthesiologist example I gave. Number 3 is air ambulance bills. 9816 does refer to other things too, like an advanced explanation of benefits. I'm not quite sure that that this external review process applies to those. It doesn't seem like they should, but it's a little bit vague in my mind here. The new regulations from last week do contain some helpful examples if you're kind of curious about it. One of them involves an employee who received pre-stabilization emergency services in an out-of-network emergency department. So again, person was out of network, they got injured, went to a local hospital there. The plan, the TPA or insurer failed to apply special rules of 9816. Again, kind of said, hey, we're going to treat this as being out of network. In fact, they should have treated it as being in network. In the past, the employee probably could not have sought external review because it didn't involve medical judgment, but under the new regulations, the employee can do so. So what does that mean from an employer perspective? Well, basically, employees have new rights, and ERISA generally requires that you inform employees of what their rights are. So I think you probably have to modify your plan and SPD to reflect these additional rights of enrollees, again, effective for plan year starting January 1, 2022. So that's, again, another takeaway, another action item for you in terms of updating your plans and SPDs here. All right, so let's go through some of these effective dates, because some of them, as I've been noting to you here, start plan years beginning January 1, 2022 and later. So those are important, right? That's roughly 2 months away. That gives employers a lot of action items to start working on. Luckily, though, the federal regulators did delay some of these other ones in some context. So, for example, the transparency regulations, which we'll talk about more, generally require public posting of in-network provider rates, out-of-network allowed amounts and billed charges, and prescription drug historical net prices. And these regulations date actually back to the Trump administration from November of 2020, about 11 months ago. We're supposed to start effective January 1, 2022. The regulators about a month ago said, wait, slow down, there's too much going on here. Let's delay 1 and 2 in terms of this public posting of these files. Now it's plan year starting July 1 of 2022 instead of January 1 of 2022. Number 3 is now delayed indefinitely, this posting of the prescription drug historical net prices due to an overlap with the CAA that, again, we'll kind of talk about more. So again, some of this is moving in terms of dates, which is good. The longer this gets pushed out from an employer perspective, a TPA perspective, insurer perspective, I think in general everyone's happy. I guess maybe plan participants are not happy, but certainly on the plan sponsor side of things, I think we are. Prescription drug and other healthcare costs were supposed to be reported by December 27th, 2021. Why such an odd date? That's 1 year after the law got signed, the bill got signed into law from last year. Then every June thereafter in terms of reporting about what your prescription drug costs. Now the first report is due a year later, December of 2022, but it does seem to include 2020 and 2021 data. So do take that into account. One kind of interesting question that I can foresee happening is what happens if you change PBMs in the interim? So your PBM in 2020 or 2021 is not the same one you have in 2022. Who's going to do the report? Because you're probably relying upon them to handle it. So that's a new kind of transitional issue that, again, we haven't really had to deal with in the past. Will a new PBM take it up or not? So again, think through that issue also, again, especially if you're changing PBMs. Price comparison tool, supposed to start January of 2022, now delayed until plan year starting in 2023. Tool is going to allow enrollees to compare expected hospital costs and things like that. It'll be very neat, very cool for plan enrollees, but it's complicated to implement, and again, it's not going to happen here soon. Advanced explanations of benefits, advanced EOBs, same kind of concept. Plan enrollees can say, hey, I want to know what this particular procedure is going to cost me from an out-of-pocket perspective. Very cool thing, very good for plan enrollees, but really complicated to make it happen because it requires a lot of coordination between the provider and the TPA or insurer. So again, that's not going to happen in January 2022. The agencies have sort of kicked this can down the road indefinitely and said we'll tell you when it's going to be applicable. We'll give you more guidance. It won't be this year. So my guess is 2023, maybe 2024, before that advanced EOB requirement actually begins to apply. New ID card requirements. This is interesting, and along with provider directory requirements, continuity of care requirements. No guidance is coming soon. The regulators just said, we don't have time to get out guidance. But instead of delaying the effective date, they said, no, you have to have good faith compliance until we actually get around to telling you what you have to do. So that's kind of a tougher one. That means you do have to kind of work on this and make sure that you're complying with those rules. And again, we'll go through those in a little more detail here in the upcoming slides. No contractual gag clauses. Again, no regulations coming soon, but compliance, other than kind of a required report to the federal government, is going to be important here. As we talked about before, the Alliance has actually been kind of a leader in this area in terms of not having those gag clauses. So I suspect that most people on the phone today are actually probably in better shape than many other entities which don't use the Alliance, to be blunt. So this one is actually, you're probably in better shape maybe than you even knew on that one. All right, let's go through some of these other kind of nitty-gritty details here. Identification cards, the plan and issuer must include in clear writing on any physical or electronic plan or insurance ID card the following information: the deductible for the plan or coverage, any maximum out-of-pocket, telephone number and internet website address for the individual to seek consumer assistance information. We have seen, by the way, some big TPAs, national TPAs, at least one of them, push back on this and say, you know what, it's too complicated for us to put in your particular plan's deductible, your particular plan's maximum out-of-pocket. We just want to list an internet website, and then people can go there, they can log in, they can try to remember their password, they can hopefully, click through different buttons to figure out what their maximum out-of-pocket is. We've been pushing back against that because to me, the whole point of this is that enrollees don't have to do that. It's right there on the card in terms of deductibles, maximum out-of-pockets. So again, you should double check that with how your TPA is handling it. We've seen some pushback and reluctance by TPAs to actually do this here. Another NSA change, provider non-discrimination rules. The ACA had a special provision saying that plans cannot discriminate against a provider acting within the scope of that provider's license or certification under applicable state law. And nobody really knew what this meant. Nobody really knew what we had to do. In April of 2013, the federal regulators came out and said, we don't know really what it means either, but it's self-implementing. You guys figure it out. So the best example I've ever come up with, it would be like a midwife who is licensed under state law. Sometimes plans don't cover midwives. They want people to go to the hospital to give birth. Might be safer, et cetera. And so they kind of force and steer people to go to a hospital and exclude midwife coverage. Maybe that's a violation of this rule. That seems to be kind of the best example. But it's still a little unclear. The NSA kind of called the federal agencies out on this and said, no, you have to actually provide some guidance. So we expect some guidance, just not quite sure when we'll actually get it, though. Next NSA change, continuing care. Effective for plan years starting January 1, 2022. If the plan enrollee is getting care from an in-network facility and then suddenly it becomes out-of-network, so the facility or a particular provider no longer is in-network, then some special rules are going to apply where the enrollee basically has a right to elect continued transitional care from the provider. I tend to think of this as almost like COBRA for continuing care patients. So it's kind of it's a brand new right. I think of it as like a COBRA right, if you will, just to maintain that in-network status. The enrollee is going to receive a notice about that. So again, your TPA should be identifying if they need a notice and maybe sending it out. Maybe they'll look to a COBRA vendor to send out the notice. I don't know. Maybe they'll look to you as an employer. Again, I think it requires further conversation. Who is a continuing care patient? It's not everybody. They have to have a serious and complex medical condition, undergoing non-elective surgery, pregnant, terminally ill. So it's not me for my hangnail treatment or something like that. It's significant medical issues in terms of what people are going to be subject to this. So again, you need to kind of, I think, work through this and talk to your TPAs and figure out who's going to make that call, who's going to send out these notices. Advanced EOBs, again, this was supposed to kick in 2022. As we just noted, this will actually be delayed here, probably indefinitely. But the advanced EOB is going to be very cool for plan enrollees. If they have a medical procedure which is scheduled, they will be able to call up the provider, call up the plan, the TPA, and say, hey, I want to know how much this particular procedure is going to cost me. The provider and the TPA are supposed to talk and then kind of get back to the individual very quickly within 1 business day, unless the item or service is scheduled for at least 10 business days away, in which case they have 3 business days to come back and say, okay, here's what this is going to cost. If you pause for a second and think through that, 1 business day is incredibly fast. I mean, if you're having some kind of complicated surgery, you can just imagine, somebody needs to figure out, okay, for this particular surgery, what is everything that could occur? The provider has to figure that out. Provider has to communicate it to the TPA. TPA has to communicate it back to the enrollee within 1 business day. It is a very heavy lift. And that's, again, why I think the regulators have delayed this because it requires a massive amount of coordination between entities that, do talk to each other, but maybe don't talk to each other that quickly or that thoroughly. So this will be very interesting, when it comes out and when it applies. But again, we're not quite there yet. You can put in certain disclaimers. You can say, hey, these are good faith estimates. They could be subject to other medical management techniques like prior authorization, things like that. So there will be some standard language kind of associated with these advanced EOBs. But again, we don't have that developed quite yet. Speaking of other kind of really cool things, interesting things for plan enrollees, price comparison tool. And again, the goal here is to have group health plans and health insurance issuers offer price comparison guidance by telephone and on the internet, so that, again, a plan enrollee can call up and say, hey, I want to know how much this service is going to cost me. I don't have anything scheduled yet, but I want to know how much this is going to cost to go in and get this particular procedure. So again, as you can imagine, depending upon the level of the complexity of the procedure, going to require coordination between the TPA and the provider to figure out what does that procedure entail, what are the likely, medical services to be provided, and things like that. So again, really interesting, but again, a little bit delayed here because we don't quite have the guidance on that. Provider directories. This one is interesting too. Right now, no doubt you have a provider directory. You kind of tell people who's in network and who's out of network. That's very standard. We've had that for a long time. This kind of takes it to the next level, and it says that group health plans and insurance issuers have to provide enhanced directories of healthcare providers. The provider's name, which again you probably have right now, the address, that's fine. Specialty, you may not really have the specialty listed. Maybe you do, maybe you don't. The telephone number, digital contact information, which I think is an email. We don't have a regulation saying that, but I think that that's probably true for in-network providers. And again, that last piece for sure, I think is new, at least in terms of what I've seen. At least every 90 days, the plan and issuer must verify and update the provider directory information. So sometimes right now, this doesn't happen every 90 days. It might be more of a once every 6 months, once every year kind of process. 90 days is now a hard standard here. And the plan has to remove providers and facilities if they can't verify the information. In addition, The plans have to update their database within 2 business days of receiving notice from the provider of a material change to that provider directory information. So again, TPAs, if they're providing you with that directory, maybe in the past, maybe did it once a month, once every 3 months. 2 business days is the new standard. And then, again, we have to get back to enrollees very quickly if they ask questions here about what is actually covered. There also has to be a database on a public website of the plan or issuer, which kind of lists off all these different in-network providers. It's not quite clear when they talk about a plan's website, what does that really mean? Is it the employer's website? Things like that. Again, a little bit unclear. There also has to be a written provider. In the written provider directory, it has to state that the information in the directory was accurate as of the date of publication, that the enrollee should consult the database to obtain the most recent information. And then the real kicker is the last one here. If the plan or issuer incorrectly tells the enrollee that the provider was in network or that the item or service was in network, then the plan or issuer is limited to what the cost sharing would have applied at the in-network level. So to me, that's significant. It's a very large incentive to get this right, because if you are wrong, then and that enrollee relies upon it, goes to somebody that in fact was out of network, you can only charge them at the in-network level. So in-network, maybe you pay 90%, out of network, maybe it's 50%. Suddenly for this particular service, for this particular individual, you're at the 50% level, or I'm sorry, you're at the 90% level in terms of what you have to pay, not 50% level. So very significant kind of hammer here, to get this right. I think it raises very interesting questions about how you're able to track it. If an enrollee logs into a website, it's a public website, how do you prove what they saw? How do you prove it was them? Should TPAs be keeping a record of every single iteration of their web page and then tracking which individuals saw those particular web pages, if that's even possible? Because I can just see how situations will pop up where someone could claim, hey, I was told that was in network, but in fact, they weren't really told that. They didn't really look on the website. So I think this could be sort of messy here in terms of trying to prove, did this particular enrollee really receive bad information, or are they just sort of making it up? So again, to be determined. We'll see where that one goes. All right, no gag clauses. We've hinted at this one a couple times. Let's kind of get into the details a little bit more. Group health plans and health insurance issuers cannot enter into an agreement with a healthcare provider, network, or association of providers, or other service providers like a TPA that would directly or indirectly restrict plans or issuers from offering certain information, including provider-specific cost or quality of care information through a consumer engagement tool or any other means to the people who are in the plan. Same thing with electronically accessing de-identified claims and encounter information or data for each enrollee upon request and consistent with other applicable laws, including financial information like allowed amounts, claim amounts, provider information, service codes, things like that. And, again, in the Alliance context, this may not seem very revolutionary to you all, but I can tell you that I've fought many a battle over the years here on behalf of self-funded employers, where it's been a real struggle to get some of this data from insurers and TPAs and PBMs, probably to a lesser extent, but insurers for sure, very difficult to get any kind of information from them. And don't get me wrong, they have their reasons for doing it. I mean, it's kind of their crown jewel, so I get it. But this is a whole new world in terms of sharing information. And I think it's going to be beneficial for plan sponsors to work with your brokers, your consultants, to kind of analyze the data, analyze trends, really get behind the numbers, figure out where you're going from a health plan perspective in terms of cost. So a lot of strategic implications about this. And as Cheryl noted before, I think the Alliance will be doing a different session in terms of talking about some of the strategies that these changes in law will reveal here, if you will. The no gag clauses, eventually we have to tell the federal government and attest to the federal government that you're in compliance with this requirement. We don't quite know when that one will apply. In theory, this rule applied immediately, December 27th of 2020. So in theory, everyone has been complying with this rule for the past 10 or 11 months. In reality, I don't think that many people have done very much here. I think that, that part of the reason is we weren't quite sure what was going to be required. We're kind of waiting for more guidance. Now that we know the regulators really aren't going to be issuing any more guidance, now I think it's more appropriate to start kind of drilling into the contracts that you have with your vendors, and for your vendors to drill into the contracts that they have with the providers, which also may have kind of these gag clauses. And everybody, I think, needs to start kind of unwinding those provisions, modifying the agreements, taking out those kind of provisions. We have had some questions from clients about, instead of going through each contract and kind of rolling up our sleeves and getting our fingers dirty, looking at things, could we just say, hey, our contract says that both parties agree that they'll comply with all applicable laws. Would that be okay here? Maybe it's okay here. I can tell you that in other contexts, sometimes the federal government doesn't like that. For example, in the HIPAA Business Associate Agreement context, HHS has said you can't just have one sentence saying you both agree to comply with HIPAA. They want to see a full, 4 to 7 page HIPAA Business Associate Agreement. In other words, they want you rolling up your sleeves and getting your fingers dirty and actually, putting ink to paper there. So would they require the same thing here? I don't know. Again, we're kind of in this gray area. So again, I think it's probably worth thinking through that in a little bit more detail. But again, I think Alliance members in general are probably in better shape there. Other NSA changes here where, again, we don't necessarily have a lot of the details. Compensation disclosures. Group health plans must disclose for certain brokerage and consulting services certain information if the cost of those expenses is going to exceed $1,000 in direct or indirect compensation. Various information has to be in there, like the services to be provided, statement that the service provider will provide services as a fiduciary if they are. That's an interesting one because sometimes service providers dispute whether they're a fiduciary. It can be unclear if they're a fiduciary, so this might nail it down in a little more detail. Talk about all the direct compensation that's reasonably likely. Also describe indirect compensation that they may receive. Are they getting some kind of commissions or other payments from another service provider down the stream somewhere? Again, kind of transparency is the goal here. So again, lots of kind of little moving parts here in terms of what will probably have to be disclosed at some point. If there's an error in making the disclosure, generally have to correct it within 30 days. If the plan sponsor or fiduciary becomes aware that your service provider is not doing this, then you have to request in writing that they furnish the correct information. If they refuse, then it's on you as the employer or plan fiduciary to tell the federal government about the situation. So again, you have to be kind of monitoring, you have to be a little bit more vigilant because of this new requirement. In addition, if a service provider really won't do anything here, or maybe if you have a dispute about what has to be reported, there's actually an affirmative obligation on you to terminate the contract, subject to any kind of duty of prudence. So again, a lot of interesting parts there. It does only apply to brokerage or consulting services, probably not to PBMs or TPAs, but sometimes TPAs or PBMs might provide consulting services. So again, it's a little unclear in terms of what's going to be required here. There's also some arguments that this regulation only applies if ERISA plan assets are involved because it's under the ERISA prohibited transaction rules. And what does that mean? That means that if the employer is just kind of paying for these services, or if the amounts that are being paid to the vendors here are not ERISA plan assets, they're just money that has never been an ERISA plan asset, it's just kind of general checking account money of one of these other vendors, then maybe this rule kind of drops out. So it's, there may be some exceptions here, but we're just not quite sure how it's going to work. There were some new regulations that came out last month, which relate to this particular rule, but only for individual coverage or short-term limited duration insurance. Those regulations are interesting. If you're curious as to what they say, double check them. Those do not apply to group health plans, so they technically are inapplicable to your group health plans. What I'm kind of speculating about, though, is I think the DOL and IRS may just adopt these rules and apply them in the group health plan context. So if you're looking to get kind of a heads up about where this might be going, that might be an interesting place to start. But again, not technically applicable there. All right. Other changes here. So again, sorry, there's a lot. I told you that there would be a lot here, and I hope I'm not disappointing. Mental Health Parity and Addiction Equity Act, MAPIA here. Many of you provide mental health or substance use disorder benefits in your group health plan. That's a very typical kind of benefit. You have dealt with and lived with mental health parity for a number of years. Presumably you're fully compliant with it, but the NSA added a brand new requirement that has caused a fair amount of panic, I would say, here because of very stringent enforcement by the federal government, especially the Department of Labor, where we've seen them start asking for a written comparative analysis of how the non-quantitative treatment limitations under your plan to verify that they do not apply more stringently to mental health or substance use disorder benefits compared to medical surgical benefits. And we've helped out a number of clients with this situation. The DOL has been very aggressive. When one of our clients gets one of these letters, there's probably, it started off honestly as 10 calendar days to reply. The more recent letters we've been seeing say that you have to reply within 5 calendar days, and at least to kind of a narrow piece. They sometimes give like 30 days for a broader piece, but very stringent. This is, I would guess, probably the number one thing that the Department of Labor is interested in enforcing right now. This is top of the list, absolute high priority. You know, full support by both Republicans and Democrats. It has bipartisan support. So, plus the DOL has to report back to the federal government, to Congress, by the end of this year in terms of their enforcement actions here in 2021. So they need some data, they need some enforcement activities to show to Congress, and they are aggressively pursuing it. So in terms of what is required, you need to basically kind of analyze your plan. Look at your plan document, identify all your mental health or substance use disorder benefits in different categories, like in-network, out-of-network, things like that. Talk about all the factors that you use to come up with the NQTLs. Let me back up. An NQTL is kind of a non-quantitative limitation you have under your plan. Best example of that is probably a prior authorization requirement. So if somebody on the medical surgical side is going in to get an organ transplant, very expensive procedure, you almost always have a prior authorization requirement there. On the behavioral health side of things, maybe residential treatment facilities, expensive to have somebody go and live somewhere to get treated for their mental health conditions. You may apply a prior authorization requirement saying, hey, you need to get that pre-approved. If it's an emergency, maybe we'll cover it for 3 days or something like that. But longer term, we need to get that pre-approved. Those are examples of a non-quantitative treatment limitation. I've identified about 23 common, or well, some are less common, NQTLs, which I've seen various plans use. So you kind of need to go through your plan, comb through it, figure out which of the 23 NQTLs you use in the plan, and then for each of them, again, kind of come up with this evidentiary standards, kind of list through, why are we using this? How do we come up with it? How do we update it? How do we prove that under the plan document and in operation that we're not applying it more stringently? And this in particular, the and in operation piece is tough. If you have, somebody who says, we'll just look at your plan document, that is not sufficient, I do not think. I think you really need to go beyond that. I think you need to talk to the TPA, you need to talk to the PBM. It doesn't have to, necessarily be, an adverse kind of situation. I think you can kind of just talk to them and hopefully kind of work through things. But it will require some, discussions with the TPAs and PBMs, I believe. Then after you've done all that analysis, you need to write down your specific conclusions. Hopefully they say that you comply. If you don't comply, you have to say you don't comply, and you're kind of confessing your sins. And then you don't have to automatically provide this to anybody, but you have to have it sitting around and kind of ready to produce, so that the Secretary of HHS or DOL or IRS asks for it, or an enrollee asks for it, or maybe a state regulator asks for it, then you need to produce it. If it's insufficient, you'll hear from the DOL, and we saw one of these letters last week from the DOL, where they came back and said, we think that what you gave us the first time is insufficient. Here's a nice little list of 18 different follow-up questions, and you have 5 days to respond to these 18 detailed follow-up questions. So again, this is a top priority. If you haven't done anything here, you really need to start moving on this one, I think, because you'll be very challenged, I think, to respond within 5 days if you haven't kind of done anything on it. So start working on that one, I'd say. NSA drug price reporting. Again, we talked about this one a little bit, hinted at it before. New prescription drug reporting, which was supposed to have been required here in 2021, now again got pushed down stream here a little bit. What do you have to include? Some basic information, the beginning and end dates of the plan years, number of enrollees, state in which coverage or plan is offered. That one is a little bit curious to me. I mean, what if you have a college student away at college? Does that mean that they're now in a different state where the coverage is offered, or can you really just look at where your actual employees are? I'm not quite sure about that one. That's kind of an open issue. 50 brand prescription drugs most frequently dispensed, also the 50 most costly drugs, 50 drugs with the greatest increase in plan expenditures, total spending on healthcare services by the plan or issuer, impact on premiums by rebates, fees, and other remuneration paid by drug manufacturers, and all this gets reported to the federal government. The federal government kind of de-identifies it and puts it out there within 18 months for everyone to kind of look at and sort of analyze for trends. Again, more transparency is what we're seeing here. All right, other transparency rules. Separate and apart from all these Consolidated Appropriation Act changes and the No Surprises Act changes, very confusing that we have different transparency regulations. These are from November of 2020, so I tend to call them the November 2020 transparency rules. Do they overlap with the CAA? Absolutely. And again, the federal government has cited the overlap here, very confusing overlap, in delaying some of these rules. And we mentioned one before in terms of public posting of machine-readable files of 3 types of information. Again, all 3 of those have been delayed here, one of them kind of indefinitely. This applies to self-funded group health plans and very unusually fully insured plans. So if you have a fully insured option in addition to your self-funded option, go back to the carrier. If the carrier agrees in writing to comply with this, then you're off the hook. If they don't agree, then you're stuck. I would be very surprised if they would not agree to it, though. But do talk to them again if you are fully insured somewhere. If you're self-funded, again, same kind of story. Go talk to your TPAs, go talk to your PBMs about providing these negotiated rates, the historical out-of-network rates, and the prescription drugs. And again, a lot of this just got delayed. The prescription drug is kind of indefinitely delayed. First 2 were delayed until middle of 2022, giving us some breathing room, but it's not a complete delay. We're going to have to deal with it eventually here. Looking down the road in 2023, there is more that has to be disclosed. Estimates of cost sharing to an enrollee and 500 specified items or services starting in 2024. It's all covered items and services, through online tools and in paper. Again, a lot of disclosure. Plan enrollees need to be able to be told what these different things are going to cost. Very interesting, very cool if you're a plan enrollee. All this level of detail that you're going to be able to get. The accumulated amounts, your in-network rates, negotiated rates, and all this. But again, it's going to take a while for the industry to sort of catch up and be able to produce, all these different statements and estimates and things like that. So again, just kind of glossing over those because they're more of a 2023, 2024 kind of issue. All right. Let's jump into sort of a grab bag of new guidance. And again, some of these are important. Next slide on COBRA, I think, is very important, actually. This one's just kind of a weird one. Sometimes TPAs and PBMs and insurers will record phone calls made by enrollees or create a transcript of them. There's an interesting Department of Labor opinion letter now saying that enrollees have a right to get copies of those recorded phone calls. And that's very interesting. That had never really been clear before. And this does pop up on occasion. So again, TPAs, insurers, PBMs need to kind of update your procedures, need to keep this in the back of your mind. If you're an employer and if somebody says, hey, I called the TPA and I want a recording of that phone call, in the past you may have shrugged your shoulders and said, I don't know if you can get it or not. Now the answer is yes, you do have to provide it. So that's interesting, kind of obscure, but sort of interesting. Last week, again, kind of a significant change here. New IRS Notice 2021-58, where the IRS clarified this, how they phrased it. I would reframe it as significantly and unexpectedly modified their prior guidance about COBRA and the COVID delayed time period. You may recall that under the prior guidance that we got last year from May of 2020, basically the Department of Labor and the IRS and HHS said, hey, due to COVID, we're giving everyone like another year or so to make elections. And then they came up with more guidance and said, hey, actually, it's even longer than a year. Everybody gets a year for each particular individual action. So it could even stretch out even further, maybe a year to elect special enrollment and add a child. And then if that bumps up your cost, maybe it's another year to pay for that increased cost. So quickly you add it up, and it could be years before things actually are paid for or elected, way after the actual effective date of the change. So very confusing, very difficult to administer, and create a lot of issues. For example, we put in an example here. Let's suppose an employee terminated on October 1 of 2020. Employee normally would have 60 days plus a year to elect COBRA. 60 days is your standard time period. Then 45 days plus a year to pay for that first month's COBRA. So the initial payment could be years, literally over 2 years after the termination of employment before you first get that first payment. The new rules are good for plan sponsors. They cut back on that. They say basically, no, that's not how it's going to work anymore. And they introduced this brand new rule, which kind of tightens things down quite a bit. But it's a change, and you may have communicated the opposite to employees previously. And if you have, then now I think you want to go back and say, wait a minute, we told you what we thought you had in terms of timing based upon last year's guidance. This year's guidance has now cut back on it. You don't have as long now to make these payments. It's not going to be years down the road before you make your first COBRA payment or your second COBRA payment. Everything has been tightened up here. The new rule, if the individual elected COBRA outside of the initial 60-day COBRA election time period, that individual will have 1 year and 105 days after the date the COBRA notice was provided to make the initial COBRA payment. So again, kind of a lot of moving parts in there. 1 year is that COVID relief. 105 days, what is that? That's the 60 days to elect plus 45 days to pay. Time period kind of baked in there. And it's triggered from when the COBRA notice was provided. So you have to go back to your COBRA vendor if you have a COBRA vendor and make sure that you can track when that notice was actually provided. And again, kind of run your time periods from there. If the individual elected COBRA within the initial 60-day time frame, so again, one is outside of it, one is inside of it, he or she has 1 year and 45 days after the date of the COBRA election to make the initial COBRA payment. So again, this is, I think, a significant change. I think it's essentially a new rule. I think the IRS is kind of admitting that it's a new rule because they provide a transition relief period, which says, okay, despite this new rule, everyone always has at least until November 1, 2021 to make that initial payment. But November 1 of 2021 is creeping up on us very closely. If you have told people the opposite, again, you probably want to get out an initial notice here or a new notice saying, hey, here we previously told you didn't have to pay until X date. Now with this clarification, maybe we want you paying much more quickly in that situation. The future premium payments are going to be due 1 year from the date that the payment would have originally been made. The new notice, again, I didn't have time to go through every example, but there's 10 kind of detailed examples. We think you should take a look at them. One of the examples is here. This is example 2 in the new notice. Kate is a participant in Employer-Wise Health Plan. Kate has a qualifying event, receives a COBRA election notice on October 1 of 2020. Kate elects COBRA on October 15th, 2 weeks later, retroactive to October 1 of 2020. And again, Kate didn't have to. She could have sat on this for a long time period, about a year, a little over a year, but she did act pretty quickly. By when does Kate make her initial and ongoing COBRA premium payments? Kate has until November 29th, 2021 to make the initial payment, i.e. 1 year and 45 days after when she elected COBRA, October 15th of 2020. That rule would be different if Kate had elected outside the regular 60-day time period, but she did not. So again, kind of nitty gritty, figure out, qualified beneficiary by qualified beneficiary, what are the time periods that apply. And the initial payment Kate makes will be for October of 2020. November 2020 payment is due by December 1 of 2021, 1 year and 30 days after the November 1, 2020 payment. Premium payments are going to be due every month after that. Kate's COBRA should end on March 30th of 2022, but her last payment for March of 2022 will be due in October of 2022. Query whether Kate will really keep paying for that. I mean, maybe she will, but if she didn't have any claims in March, why is she going to keep paying through the end of October? So some potential adverse risk here from the employer perspective. You could see some people, again, kind of gaming the system. Action items for employers: double check your prior communications on COBRA and COVID. Likely did not interpret the guidance this way. I think this is brand new. If you want to hop on the bandwagon here and kind of cut back on it and clarify things, you should send out a notice, I think, pretty quickly to tell qualified beneficiaries what is going on here, what their time periods are. A couple other sort of quick things we wanted to mention here: the continuing saga, if you will, of ACA Section 1557. 1557 will not apply to everyone on the phone call, only applies to entities that receive federal financial assistance, usually hospitals, healthcare providers, public colleges or other kinds of colleges that maybe get student loans, again, providers that receive payments from the federal government, like through Medicaid, Medicare, kind of things like that. So, if you're just a widget manufacturer making widgets, probably doesn't really apply to you. But in any event, this 1557 rule says that your health plan cannot discriminate on the basis of sex. The Obama administration position was that sex included LGBTQ status, and therefore health plans had to cover gender reassignment coverage. Trump administration said, no, we disagree with that. We're going to take the opposite position. You don't have to cover it. May of 2021, Biden administration comes in and says, nope, we disagree with the Trump administration. We're going back to the Obama administration interpretation. We're going to apply this broadly. So that's kind of a ping pong game going on there. Also, a lot of litigation going on here too. EEOC, we've seen be very active in their context, the Title VII context, different than 1557. We have seen within the last month the EEOC bring a claim against an employer for not providing this type of coverage, gender reassignment coverage. So even if 1557 is in dispute, EEOC continues to be active with respect to a different law, Title VII of the Civil Rights Act here. So again, fair amount of moving parts there. All right. A couple other quick things here before we run out of time. EBSA cybersecurity guidance. In April of this year, EBSA, which is the DOL, issued a best practice documents for plans that hold assets and maintain personal data on participants, saying that plan fiduciaries have to look at this, kind of focus on it, especially focus on what your service providers are doing. They list off 12 different things. I've mentioned a couple of them, 3 of them in there. This guidance is definitely applicable to retirement plans, It's a little bit unclear how much it impacts health plans. It could impact health plans, so I think there's some incentive to maybe update business associate agreements to include some of these additional items. I think your business associate agreements probably pick up the majority of the things which are out there, but probably not everything. So again, it might be something to add to your to-do list to kind of mention that too. One other HIPAA-related change, this one has not received much notice in the press. Earlier this year, President Trump signed into law the HIPAA Safe Harbor Bill, saying that HHS will take into account the covered entities or business associates' use of industry standards which are promulgated through statutory authorities. If they have been using those industry standards, like NIST standards, which are very tough standards, really designed for kind of governmental entities, big entities. But if you're following one of these recognized standards, then you're less likely to be hit with a penalty if there is a breach, or if you get hit with a penalty, it'll hopefully be less. So look at it, figure out if you kind of meet those standards, maybe talk to your IT department, maybe update your HIPAA security policies and procedures. But again, you don't have to, but it could help you in the event of a potential breach. Different topic, about a year ago, the Fifth Circuit held that HHS's penalty against a Texas medical provider was not allowed under HIPAA, basically saying that they're doing it wrong in terms of handing out penalties. Really nice. If you are facing a HIPAA breach and a large HHS penalty, gives you another argument to make, kind of a defense. But again, hopefully you just don't have a HIPAA breach to begin with. All right, that was a lot, so my apologies. But are there questions, Cheryl?
Thanks, John. I think we owe you a box of throat lozenges. That was,
yeah, seriously.
that was great. Yes.
Trying to talk quick. Yeah.
But really good. Thank you. Yeah, so we have time for questions. If people want to type them in while you do, we've got a couple already, but while you do that, I will just make one comment maybe about something that you shared with us early on, which is I think you called it, you referred to it as the $1 million or the multi-billion-dollar question about whether transparency is going to lead to higher or lower prices. And we have a theory about that, John, and that is that it's largely dependent on how the market responds to the information that's made available. If we, as purchasers, figure out ways through plan design and other incentives to encourage our employees and plan participants to go to providers that do a good job and cost less, they'll be getting increased market share. And so we think that there will be a business reason for them to keep their prices low, just like in the rest of the world. If the market doesn't respond, if no one acts on the information that becomes available, we think it's likely that the prices will increase. And why wouldn't providers raise their prices if they see that others are getting away with it?
Yeah.
So that's our theory. We'll see how it all shakes out, but I like it that we see ourselves as having a role to play in how the world unfolds. And so we're working hard on that.
Yeah. No, it makes sense to me. And yeah, I'm glad that folks like you, smarter than me, are kind of weighing those more difficult questions, Cheryl. So that's great.
We have different sources of influence. I have no, I mean, yes. Anyway, so we do have one general question. A lot of the things that you talked about today really fall to the TPA. And so the general question is, how much do employers really need to pay attention to the stuff that their TPA is responsible for?
Yeah, that's a great question. So you should be paying attention to it. ERISA does have a fiduciary duties which apply to you as the plan sponsor, and one of those fiduciary duties is the duty to monitor your service provider. So baked right into ERISA ever since 1974 has been this duty to monitor. People tend to forget about it because it's kind of so old, but you actually have under ERISA just this general fiduciary duty to monitor the TPAs or other service providers. There's also a very concrete reason to do it, and that is that the agencies throughout the different regulations they've issued over the many decades now. They emphasize that if a vendor messes things up, they're not usually going to go after the vendor. They're going to go after you as the plan sponsor, because ultimately it's your job. These rules talk about how they apply to the group health plan. The group health plan is your group health plan. These rules do not directly apply to TPAs or PBMs. Generally speaking, they generally apply to your plan. And so the regulators could pursue you. If you bring in the TPA, so be it. But yeah, the initial liability probably lies with you. So yeah, I think it's worth paying attention to for sure.
And just a reminder for the people that are tuning in today, John's presentation, the checklist that I referred to in the beginning that lays out all the things that you need to be talking with your TPA and other plan partners about, as well as a recording of this session, will be available on the events page of our website. So if you no doubt missed some things, want to hear this again, or want to share this with others, that'll all be available to you. Okay, some more specific questions. Can an emergency claim, John, go through both IDR and external review?
I think it's a little unclear. It's funny. That's a great question. I think I actually had a bullet point on that in the slide deck, and then I wasn't quite sure about it because they both are framed as being kind of the final decision maker. So I am actually intrigued by that question myself because again, they're both supposed to be the final process. So I'm not 100% sure about that or whether it's really specified. My gut reaction is that I'm just not sure because again, this is kind of getting into the weeds, but in the IDR regulations, they talk about how the IDR's determination can only be overturned pursuant to a federal arbitration law, which protects arbitrations as kind of standing. And it's hard to do that under that. You have to show kind of like fraud or undue influence or things like that. On the other hand, the external review piece of it, again, now seems to pick up situations where the payment process, the 9816 section of the code, that payment process is not followed. So I'm not quite sure which one takes precedence. So it's a great question, and I know it's an issue. I just don't quite know the answer.
Okay. Wow, we stumped John. That never happens. Another question, should health plans just make the initial payment amount equal to the QPA?
Yeah, I think so. I mean, I think that'll probably be the starting point is that qualifying payment amount, which is kind of, again, as you may recall, taking what we would have paid back in January 2019, applying sort of an inflationary number to it. I think that'll be kind of a typical approach that the plans or the TPAs on your behalf will take in that situation. And then we'll see where it goes. We'll see if that really is accepted or not.
Okay. Next question. Is there anything that will stop providers from contesting the payment amounts for every claim? And what should we be considering when it comes to dealing with arbitration?
Yeah. Interestingly, there is kind of a 90-day cooling off period, which is baked into the regulations. I didn't get into that level of detail, but it will prevent either side, the providers or the health plans, from initiating this process over and over again for the same kind of claim. So there's this sort of 90-day, you can't bring the same IDR claim against the same provider for the same kind of service. So there's kind of a 90-day cooling off period. Now, that's only for the same provider for the same service. There's lots of different services out there, so lots of different providers. So, you could imagine a scenario where people are constantly, haggling over things and kind of fighting with each other. I think the natural break on that will probably be the cost and the time associated with it. These are going to take some time to prepare for. There's going to be the IDR entity's expense. Goodness only knows if you have to bring in like a lawyer like me for consultation, who knows what the expense is there. So I think there'll be a natural kind of break on it from getting out of hand in terms of having too many of these because of that 90-day cooling off time period. and then just sort of the natural expense of going through this.
Another question related to what you think might happen with arbitration. So once a claim ends up in arbitration, what do you think might be some factors that could influence the arbiter's final decision?
Yeah, that's a great question. And so in last week's regulations, so this had been a little bit unclear. Last week's regulations, again, kind of getting into the weeds, didn't cover it in the slides, but they do talk about how the IDR entity really shouldn't be considering a lot of other factors other than what kind of this traditional cost has been. On the other hand, they do lay out the possibility that additional factors could be introduced. If it's a very complex medical situation, if the provider has a lot of experience, those could be factors which would apply. They cite an example of like a simple laceration. So if I cut my finger open and the person who is giving me 10 stitches is a first-year doctor just out of medical school versus a doctor with 40 years of experience, they say, hey, experience is not really relevant, right? Every doctor, whether 1 year of experience or 40 years of experience, should be able to put in 10 stitches. But if it's, a complicated thing, you probably wouldn't want a first-year, doctor doing, brain surgery, complicated brain surgery or something like that. So there are some factors where which the TPAs can introduce and the providers can introduce to kind of counter them. But in general, it's really going to be that historical price.
Great. Well, in the interest of time, we're going to leave it there. John, thank you so much for sharing all of this information with us today. It's been awesome. And, it's a lot, but it's what's happening. And I just want to put in a plug for employers to become more involved in health policy matters. The Alliance has an active health policy function. We have a health policy committee that we rely on to help guide our positions on various policy matters. And we also reach out to employers periodically to invite you to weigh in on various issues that will impact your health benefit plans. It's so important for legislators and lawmakers to hear how policy proposals will really play out in the real world in your organizations. And so we're doing everything we can to make it easy for people to sign on to a letter, to provide you with talking points to use in conversations with lawmakers. But I just urge you to, if this is something that either frustrates or interests you, to reach out to me or through our website to express your interest in getting more involved. We'd love to be working more closely with more members of the Alliance. So with that, let me just thank you all again for attending today. And you'll receive the post-event survey via email soon, which will include the link to, again, the employee checklist that John created for us. And in the survey will also be directions on how to apply for CE credits if that is relevant for you. So John, thank you again for joining us. Certainly more to come on these topics, and everyone have a great rest of your day.
Thanks.